Welcome to our Exercise Behavior Change Workshop. I'm Lynette Kraft. I'm the Vice President for Evidence-Based Practice and Scientific Affairs with ACSM. And this workshop really was initiated as a means of collaborating around evidence-based practice with our partner organization, the Society for Behavioral Medicine. And so this year we were very interested in having joint programming at each other's annual meetings. So at the end of April, we had a symposium at the Society for Behavioral Medicine meeting that brought together folks from our ACSM membership along with our colleagues from SBM. And today we're very excited to have some of our colleagues from SBM here with us to help us present this workshop. So it's been a great collaboration, and I think our first efforts at collaborating have been very successful. So I just wanted to highlight that our SBM colleagues are with us today. We have some great speakers lined up for you. We have Dr. Matt Booman, who will do a brief introduction to the workshop. We have Dr. Michael Goldstein, who's going to talk about motivational interviewing. Next, we'll have Dr. Amy Rickman, who will talk about mindfulness. And Dr. Carolyn Richardson will talk about using objective monitoring with your patients and clients. So the format for today's workshop will be that after Dr. Booman's introduction, each speaker is going to speak on their topic for about 15 to 20 minutes, and then we're going to break you into 3 groups or stations, and in those stations you'll get a chance to ask more questions and to learn more about how to apply these skills within the various settings that you're working in. And we'll spend 15 minutes at each station and rotate you between them. So I think that's it for me. Let's get started with Dr. Matt Booman, and thanks again for coming.
Okay, good morning, everyone. Thank you all for attending this morning. I just want to echo what Lynette said and said I think it's actually quite momentous that we've been able to pull this off with having sessions at both Society of Behavioral Medicine where we brought ACSM folks to talk about exercise as medicine, and then now to have this talk here at ACSM with Society of Behavioral Medicine members here. I think it's quite exciting that we're starting to collaborate, and I think that it's safe to say there's going to be a lot more to come. I think there's starting to get some momentum going, and that's pretty exciting. So I have the privilege of sort of getting us off and going and providing some introduction. My job is really just simply to sort of set the stage, hopefully to get you thinking a little bit about evidence-based behavior change strategies and how they can be applied in healthcare settings. So let me just start by pointing out this paper from the Lancet series in 2012 by Greg Heath and colleagues that reviewed the evidence around behavioral interventions around the world for promoting physical activity. It was really an exciting review as it showed that a very diverse set of strategies in promoting physical activity can be effective, included community-based approaches, worksite, school-based approaches, environment and policy approaches, and also showed success in implementing these approaches around the world. I'll just point out here that physical activity in healthcare settings was singled out with an effect size of 0.16, which isn't so bad, but not among the most effective approaches reviewed. Now, here are some of the conclusions and recommendations from this report regarding healthcare-based physical activity programs. First, provider-based physical activity counseling is currently not recommended as a single component approach. The results they reviewed suggested that the most promising approaches were those that were integrated with community efforts. And more specifically, they concluded that office-based screening and advice followed by telephone or community support does sustain long-term improvements. So that was probably the most powerful message. And I think these results are very encouraging that healthcare settings are a great place to start delivering physical activity counseling, but it also tells us that we really can't stop there. We need to find ways to connect patients with services that they need outside of the clinic. So this is right in line with what we already know about the influence of physical activity behavior. Ecological models like this are probably something you're all very familiar with looking at. It highlights that individual characteristics and individual behaviors are influenced by social, family, and community networks, living and working contexts, and environmental and policy. Since healthcare is often the first and the only contact that we have with many individuals, we need to be considering how each of these other factors are influencing patients and how they can be addressed and then sometimes leveraged in clinical encounters, and our speakers are going to be addressing some of the potential approaches here today. So I'd like to raise just a couple of challenges and then some opportunities to consider as we listen to each of our speakers today. So the first challenge is to consider that many physicians in clinical practice have received very little training, formal training in behavior change counseling. However, I think this actually is changing, and we can learn a lot from colleagues in tobacco control field. For example, in a recent global survey, they found that 27% of medical schools taught a specific module on tobacco control, compared with 11% reported just a decade earlier. Also, the World Health Organization identified that 37 of the 48 countries that were sampled had tobacco treatment training programs, and that these programs trained approximately 14,000 healthcare professionals, mostly nurses and doctors, taught them behavior change skills in tobacco control. Interestingly, 3/4 of these programs had been implemented since just 2000. So this is really growing. And ACSM, should note, is making great strides in this area. EIM itself, exercise medicine, is a large-scale training program in behavior change for practicing clinicians, and they're currently working at reaching out with medical schools as well. So the second challenge to consider, which probably isn't talked about as much, is the personal health and health behaviors of providers. So in a study of freshman medical students at 17 U.S. medical schools, nearly all medical students reported engaging in regular moderate to vigorous physical activity, and 64% met national recommendations. 79% believed it was highly relevant to their future practice to counsel patients about exercise. So you contrast that with another study where medical students were compared to residents and attending physicians, and residents and attending physicians had fewer hours of sleep, less exercise, less seatbelt use, more depression, more anxiety, and less time spent in outside social activities. So why is provider wellness important? Well, it's been suggested that it impacts healthcare delivery. In a study of women physicians, women that reported more health behaviors were more likely to practice preventive services, including lifestyle assessment and education and counseling. A recent literature review showed that physicians that were unwell were more likely to respond to patients more abruptly and less compassionately, made more frequent medical errors, lower patient satisfaction, and increased malpractice suits. So finally, and perhaps what we're most familiar with, is that providers often have very little time with individual patients. I'm sure many of our speakers will bring this up. And the amount of time devoted to prevention and lifestyle counseling is pretty limited. In reality, we're actually fighting against other lifestyle behaviors for very small amounts of time in a clinical visit when we're talking about physical activity. One study found that over 50% of the clinical visit focused on medical histories and 20% on health education. 3% of time was spent on nutrition, 2% on exercise, and 1% on smoking cessation. It should also be noted that it's not just about how much time is spent on health behaviors, but how that conversation is delivered. And each of our speakers, I think this is the crux of what many of them are going to be talking about today, is going to be talking about the how this can be delivered more effectively. So along the line with challenges, there are a number of emerging trends that I think are great opportunities for us to integrate behavioral counseling into clinical settings. The first is team-based medicine in primary care. If we're going to deliver this message, we can't rely upon the single provider to do it. We need to think about how we can deliver it in teams. The second is a new term, patient-centered medical home, talking about how we can facilitate partnerships between patients, families, healthcare teams, and take into account patient preferences and needs to promote better coordination and delivery of care. So this has been adopted by a number of organizations, and it focuses on making improvements that are both high-tech, things like electronic medical records, registries, e-health interventions, as well as high-touch, cultivating physician-patient relationships, team-based approaches, and I think this is something we're really going to have to leverage if we want to do a better job of delivering behavioral medicine. And finally, I'll just mention, as a major part of the patient-centered medical home is the use of technology and sort of this emerging as a new delivery channel. So these methods can have a lot of benefits. They can eliminate transportation costs and barriers. They're time efficient, and they can extend the behavioral counseling outside of the clinical visit. And given the growth of personal technologies, I don't need to convince you that it's already in your pocket right now. You know that these technologies are growing. We really need to start to use them. And I'll just finish with a couple examples of these. So this is some work that my mentor at Stanford, Abby King, led, where started to develop different motivational frames delivered by smartphones to change behavior. We're focused on physical activity and reduce sedentary behavior. And we found relative to a control app that each of these three apps increased weekly brisk walking and decreased sitting while watching television. I should note this was with midlife and older adults that were technology naive, so they did not have a smartphone. So these apps were meant to be delivered to individuals that did not have high sophistication in terms of understanding how to use these devices, and they used them quite well, and they did change their behavior. We're extending this work now, and actually in the VA in Phoenix and veterans with metabolic syndrome in delivering this a multi-component intervention around sleep, sitting, and physical activity, and we'll have results on that soon. And finally, another thing that's happening at ASU is Project Honeybee. So the focus of this is to sustain health through prevention and early detection and disease to improve health outcomes at a lower cost. What's unique about this is we're using technology, but we're starting at the end of identifying an important clinical endpoint. That's where we start, not with the piece of technology. And then we identify existing technology, and if we need, we work with our engineers to build new technology. And then we establish a cohort of patients, develop the evidence, and then we start thinking about commercialization with it. So it's a different slant on technology and how we can prevent disease using new technological approaches and sensors. So with that, I will finish and turn it over to Michael Goldstein to talk about motivational interviewing.
Hi there, everybody. I'm Michael Goldstein. I'm with the National Center of Health Promotion and Disease Prevention at the VA. And I just want to also thank ACSM for inviting folks from SBM. I'm a former president of the Society of Behavioral Medicine, and it's really wonderful to see this collaboration with ACSM. I want to thank Lynette. And we do hope to have more of these kinds of sessions in the future, both having folks from SBM come here and having folks from ACSM come to SBM. I forgot to ask how to advance the slides. Oh, great. So I'm going to be talking about motivational interviewing as an evidence-based approach to contribute to helping patients be more physically active. And as Matt said, no one person in the healthcare setting can be responsible for being the promoter, the motivator, and then the person who helps to coach patients to participate in physical activity, because it does take a team. And it is really great to see the integration of preventive care into the patient-centered medical home as a model and a team-based approach, because there really needs to be a team to help with this process. So the how, what we ask our healthcare providers to do is really, really important, because we want to use their time as efficiently as possible. So I just want to get a sense of the audience. How many of you have taken any training yourself in motivational interviewing? So a good number. How many of you are working within medical settings already, where you're working alongside other providers, say in primary care or even specialty care? A number of you. Anybody actually involved in helping those providers to also be more effective in providing messages to patients? Just really a couple of you. Well, it's great to have you here, and I hope particularly during the second part of the workshop, when you come to the small groups, you'll tell us what you're doing and how that's working. Because you have a very important role in not only delivering care to patients, perhaps alongside your colleagues in primary care, you also have an opportunity to help them learn these strategies, the brief interventions which may help them participate more actively in the programs that you can provide, or even using the applications. How do we drive people to the apps? How do we help them to learn about what's there? So the problem is health behavior change is challenging, no matter what health behavior we're focusing on. And as Matt said, in training programs, particularly in medicine, when I was in medical school, I had virtually zero training in health counseling and health coaching. And we tend to see the problem, not necessarily a behavioral problem, we see the problem in the person. And we think that it's the person who doesn't want to see the value. They may not also know about guidelines for physical activity, what they need to do in order to reduce their risk of disease. And they don't know how necessarily to take the first steps. Yet, what we do with this is we often, because we're taught to prescribe in medical schools, we try and give people insight. So we try and tell them what they need to do. And we give them knowledge, we try and give them skills, we develop an action plan with them, but sometimes we give them help. And how many people think this approach is effective in helping people to change? Nobody. That's great. It doesn't work very well to be scolded or to be made to feel shamed for not being involved in managing one's health. And what we have to do is help clinicians to learn that there's another way. Because if you're telling people, if you're directing people, if you're prescribing only, you end up wrestling with people. They're pushing back. The more you push, the more they're going to push back. So motivational interviewing actually was developed as an alternative approach. First, it was used in substance abuse interventions because it was found that the confrontational style, where folks sat down, sometimes not only with the patient, but with the patient's family, and told them all the reasons why they needed to get into substance abuse treatment, didn't really work very well. Some people got into treatment. Some people were, in a sense, convinced and did benefit, but many, many people resisted. So one of the leading researchers in the area of helping to get people into substance abuse treatment noticed that his interventions were most likely to be useful if the style of the interaction with the counselor was different than that traditional approach to telling, prescribing, convincing, persuading. And he found that a more patient-centered approach that looked at the person with understanding first, and then curiosity, and then identifying what it was that might be already present that could be mined and built upon in order to help them to participate. So the idea in motivational interviewing was that we form a relationship, we understand the patient, and then we identify the motivation that's already there and help to align and build upon it, then help people have the tools in order to make effective changes. So it's working with the patient, not telling or pushing. And what's been found is that it's effective across a wide variety of behaviors, not just in healthcare. It's helpful in people who have been released from prison on probation to help them to stay clean. It's been helpful in the education field, working with teachers to help them to motivate students. A whole number of areas beyond just health behavior change. So physical activity is one of the core behaviors that we can help to evoke, to connect around with our patients. And when we do that in an am I consistent way, instead of feeling like wrestling, it feels more like dancing. So we're guiding the patient, trying to identify, again, the motivation that's already there, taking one step and hope that they come with us, taking another step and hope that they follow our lead. And maybe even shifting so that they're starting to take the lead in the dancing, and we're then reinforcing and supporting rather than being the the person that's struggling to push them. So what do we know about the effectiveness of motivational interviewing? A recent review actually just came out at the end of last year that was published in Patient Education and Counseling, looked at those motivational interviewing randomized controlled trials that were done in medical settings, except they excluded mental health, including substance abuse. And they found 48 studies, and their meta-analysis found a significant effect across all studies with an odds ratio of 1.55. In that 48, there were 5 studies that focused on sedentary behavior, and when they looked at just those 5, there was also a significant effect. 1.47 was the odds ratio, pretty close to the overall impact. There were some areas that were more effective than others. Again, substance abuse intervention was shown to be the area with the most impact of an intervention in medical settings. What was interesting about this is that when they looked at factors that determined impact across all of these 48 studies, there wasn't an effect for the setting type, so whether it was inpatient, outpatient, emergency room didn't make a difference. The provider discipline didn't make a difference. So it doesn't have to be the physician. It could be another member of the team. It could be an exercise physiologist who might be next door, or an exercise therapist, personal coach even. So that's also helpful to know. And that, at least in this analysis, the number of sessions didn't have an effect. And as you'll see in some of the other work that I'll share, sometimes you see an effect even with very brief interventions, if there's an opportunity to follow up with more intensive care subsequently. So speaking of that, in another meta-analysis that was done in primary care, so these are just outpatient primary care settings, there were only 12 that were eligible for the analysis here. 9 of the 12 found an effect for motivational interviewing. And in the meta-analysis, there, again, was an overall significant effect. And there were only 3 studies that looked at physical activity, and there wasn't an effect for those 3 studies, but again, it was only 3 of the 12. But interestingly, in this analysis, even a very limited intervention, only 1 session, was related to having an effect. So as I was saying, it may be that the best way to use motivational interviewing is actually to help people to get to a more intensive intervention, to help people to participate, think about participation in one of the other interventions that we know, when delivered and people are engaged, can help them to change. And in fact, in the weight management area, our office is responsible for the VA's Move Weight Management Program. There is some evidence that if we, not necessarily us, because the study wasn't done in the VA, but if an intervention is delivered to help people participate in an intensive weight management intervention, both at the beginning and also through the intervention, that increases participation, and participation is associated with successful weight loss. Okay. Ooh, time is going quickly. We want to share some of the core principles of motivational interviewing. Then we'll have a chance to practice them. And these are the 4 areas of motivational interviewing. There's spirit, principles, processes, and skills and techniques. I realized I forgot to set Lynette, the timer. So let me know when there's 5 minutes left. I looked and it said 1 minute. I got scared. That was your time. So here's what we mean by spirit. Spirit is kind of the style. And as I mentioned earlier, when MI was discovered, it was discovered by looking at who is effective. And it's people who develop a partnership with patients where there's an attempt to understand the person and then some shared process of decision making. And acceptance is the second element of that spirit, because if you're going to share decision making, you have to be willing to accept a no without judgment. There are some people who are just not ready to make a decision to change. And unless they're in danger, and we have to, on an emergency basis, admit them, and I had to do that as a psychiatrist, we don't want to take away people's autonomy. We want to actually support their autonomy as much as possible because it's been found that supporting autonomy, offering choices, and then accepting those choices, even if they're not the ones that we think are ideal, are associated with actually better behavior change, more behavior change. Compassion is a key piece of this too. Patients often struggle to make the changes that we ask them to make, and understanding their predicament, the other priorities that they may have, the life context in which they're trying to make changes. It's really important to identify that. And working with veterans, obviously, their life, particularly if they've recently been involved in combat, is really challenging to reintegrate into care. We have to understand that, into life, I should say. We're thinking about care. They're thinking about their life. We have to understand where they're coming from, what their needs are, what their social and emotional needs are, if we're going to help them change a behavior. And then the last step, or last part of the style, is evocation. And it's what I was alluding to earlier. Instead of putting the motivation into people, we're trying to identify it, mine it, reinforce it. And the term that's used in motivational interviewing is evocation, evoking that motivation. So then, using this style, what principles have been found to guide the clinician who's using motivational interviewing? Rule is the kind of mnemonic. And the first part of that rule is resisting the writing reflex, resisting directing, resisting telling, resisting just prescribing. And seeking to understand, listening, which helps you to understand the context and understand the setting, providing empathy, reflecting back what we understand from the patient as the meaning and both the challenges and the opportunities, and then helping to empower our patients. Once they're ready, we want to help them develop the skills they need and the confidence they need in order to pursue treatment. MI also has described the process, and I'm not going to go into this in detail, but in our small sessions afterwards, we can talk about how to move through this process of engaging, focusing on a behavior like physical activity, then evoking the motivation, and finally the planning step. And as this slide indicates, the first three elements are essential and have to be present in order for it to be motivational interviewing. There are a lot of interventions that focus on planning, problem solving, goal setting. Motivational interviewing includes that, but it's not unique to motivational interviewing. So what do I mean by looking for and evoking motivation? We listen for, when we're using motivational interviewing, what we call DARN. And DARN just is a reminder, again, of the different areas we can explore. We can explore desire, we can explore ability, and we can do that by asking about what people have already been doing or what they've done in the past to find out what we can pull for. We can ask them about the reasons. What reasons do you have for becoming physically active? And then how important is it to them? What's the need? How much of a priority is it? And finally, we're listening for commitment language. When somebody says, I'm here because I want to begin an exercise program and I've already decided I want to walk regularly, I need some help figuring out how to do that, that's commitment language. We don't have to spend a lot of time using any of the motivational strategies. We can move right to planning with them. So I'm not going to spend much time on these here, but if you come to our small groups, we can spend some more time looking at the highest level of that pyramid that I showed you, beyond spirit, principles, and process. What are the core strategies? What are the core skills that a clinician can use? And they're very simple strategies. They fall into this other mnemonic. The MI people love mnemonics. ORS, open-ended questions about DARN, desirability, reasons, and need. When we hear it, we want to both reflect it back to make sure the person knows that we've heard it. It also gives them a chance to clarify and deepen whatever they're talking about. Affirm it. That means reinforce and express our satisfaction as clinicians that we're hearing them talk about something that's in their best interest, and we can identify it and reinforce it. And then summaries are just another way of pulling together a series of reflections and handing it back to a person like a bouquet that they can then take and hopefully move on to planning. So we'll talk about these other strategies. I do want to get to one other piece real quick before we stop. And, whoops. Actually, I left it out for the other discussion. It's how do we give information to patients in an MI-consistent way? How do we tell them about all the things that we know about physical activity and its benefits, particularly for different subgroups of people? How do we do that in a way that doesn't sound like prescribing or pushing and make it more of a collaboration? So we can talk about that actually when we have some time in small groups. I'm going to stop here, though, and see if you have any comments or questions about what I've said so far. How are we doing on time? So we have 2 minutes for any questions now. Anybody have any questions about what I've said so far? So should I tell you the 4 steps for giving information? Who wants to hear that? So what did I just do? I asked permission. Would it be okay to share some additional information? If you're going to share information, that's what you do. First you ask, is it okay? And in a group, it's really easy because somebody's going to raise their hand. And guess what? Most patients will say okay. If they don't say okay, it's probably for a good reason. And then they're not going to listen anyway. So what we want to do, I'll show you the steps. Did I go through it all? Here it is, asking permission. And then before we tell, we want to know what they already know. So what do you know about the benefits of physical activity? What have you heard from your other healthcare providers? How do you think it's going to impact on your conditions, your pain, your sleep problems, your depression? What do you know about that before you tell? And then when you tell, you provide it in small chunks. And the next step is checking for understanding and eliciting what not only they've understood, but what meaning the information has to them. So now that you know that being a little bit more physically active can help you with your pain, actually reduce potentially the amount of meds that you have to take while also increasing your function, what do you want to do now? Where do you want to go from here? So you can give information even in an MI-consistent way. And these are very small shifts that we can help our clinicians to do. When we meet again and have a chance to talk in small groups, we can also talk about how we can help our clinicians to see the value of using this and how we can help them to do it as part of a member of a team and in the context of other interventions that may be available to them. So thank you very much for, I'm going to affirm now, for your interest and your understanding and the nodding that I've seen, and hopefully in a small group we'll have a chance for more discussion. Thank you.
Good morning, everyone. My name is Amy Rickman, and before I begin my talk, I just wanted to acknowledge my colleague, Dr. Kelly Ann Davis, who helped with the development of this talk, and especially the handout that we'll be giving you in the breakout sessions. So my talk is titled The Physiological versus Psychological Exercise Prescription, Motivation and Mindfulness Considerations. So I have a little cartoon here that often signifies what we as exercise professionals are looking at when we're trying to help people become more active. So your VO2 max needs work, and you might want to examine your lactate threshold to keep oxygen debt from interfering prematurely aerobically versus anaerobically, but incorporating weekly sets of long intervals such as 5 by 1K at 10K pace to 5K pace with 60-second rests, or 4 by 1200 with 90-second rest. You would increase capitalization, albeit with potential negative loss to your glycogen storage, while simultaneously blah, blah, blah. So often these are the things that we are so concerned with when we're working with our patients. But if you look at maybe one of our patients to the right, he's saying, I just wanted to run. I don't care about all this other stuff. So today my talk really has you not forget about all of these physiological parameters that we're concerned with, but also take into consideration some of the psychological things or behavioral things that are going on with our patients. So how do you do that? So on the left-hand side, and I apologize, this is a little bit hard for you to see sitting out there, and this will be in your handout that we'll be giving you, and we'll talk you through this. But on the left-hand side of this slide is the FIT VP principle that you're also familiar with that comes from the ACSM guidelines, how to promote fitness and physical activity in people. So when we're giving exercise prescriptions, the physiological parameters that we want to increase, we do it through the FIT principle. So we're concerned with frequency, intensity, time, type, volume, and progression of physical activity. And typically this is how we work with our patients to improve their physical fitness and performance. So what you have on the right-hand side is really an expansion of this FIT VP principle that Dr. Davis and I came up with to incorporate more behavioral or psychological components into the exercise prescription. So these are things like flexibility, immersion, timely, talent-driven, value-centered, and people-oriented. And we'll talk you through this more so in the breakout sessions. So we have to take a step back and look at motivation when we're considering a psychological exercise prescription. So what is motivation? Motivation is the reason that we do things. So why are people choosing to be physically active? What motivates them to do that? Oftentimes it could be from many different reasons, and those reasons can also change over time. So it could be to pursue a positive outcome, such as to lower blood pressure. It could be to avoid a negative outcome, such as to maybe get off blood pressure meds or not take blood pressure meds at all. Or maybe it's just because someone likes or enjoys the behavior, specifically physical activity. So when we look at self-determination theory, which is one of my favorite theories, it distinguishes between different types of motivation. And those would be extrinsic motivation or external motivation. So people doing a behavior, specifically physical activity, for a separable outcome. Then it also looks at intrinsic motivation or internal motivation. And the reasons that someone does something because it's interesting to them, they value it, it's enjoyable to them. So there's a wide motivational spectrum that our patients could potentially have when they're becoming more physically active. So at the bottom of that spectrum is, on the left-hand side, would be amotivation or not seeing a reason for doing a behavior, specifically physical activity. On the far right-hand side would be intrinsic or internal motivation, so doing physical activity because they love it and they enjoy it. And then between the two, you have what's called extrinsic or external motivation. And there are varying degrees of external motivation that we won't have time to go through today. But your goal as exercise professionals are to move your patients on the spectrum to hopefully get them to the highest end of the spectrum, which would be intrinsic or internal motivation. And I'll talk about why that is. So if we talk to our patients and they are mainly exercising for extrinsic or external reasons, they're more product-driven. So they want to potentially reduce the risk of disease. They want to lose weight, improve their fitness. Maybe they have an upcoming class reunion, and it might be appearance-driven. They might want to reduce a clothing size. If our patients are exercising more for intrinsic or internal reasons, they're exercising because it feels good to them, it's enjoyable, and they value it. When we look at this extrinsic and intrinsic motivation, and we have some questionnaires today that you can assess this with your patients if you have time, but you can also assess this just verbally through what your patient is telling you. So if a patient is telling you that I should exercise or I feel guilty if I didn't exercise, oftentimes that would be more of someone that is extrinsically or externally driven to exercise. If someone's saying, I want to exercise, or it feels good to me, or this is just a part of my life, you can assess that they are probably more intrinsically or internally driven to exercise. And typically when we look at people, a lot of times our beginning exercisers are more externally or extrinsically motivated, and people that have been stuck with physical activity for a long, long time are more intrinsically motivated. So that's one of the reasons why you want to move people more so, even if they start out externally motivated, you want to try to move them to be more intrinsically or internally motivated. So one of the reasons that we're also concerned with moving people more from being externally motivated to being internally motivated is that research has shown us that people who exercise mainly for external reasons are more likely to drop out of an exercise program. And they're less likely to feel good about that, about being physically active. On the other hand, people that are exercising more for intrinsic reasons report more enjoyment and more satisfaction with their physical activity. So, exercise, some motivation required. So our goal as an exercise professional is to help our patients look at what is motivating them and use some techniques to move them from being more extrinsically motivated to being more intrinsically motivated. So what are some ways that we can assist people with moving extrinsically to being intrinsically motivated for physical activity? So if we look again at the self-determination theory, it proposes that there are 3 psychological needs that can help people to be more intrinsically motivated. And so the 3 things that I would like to highlight that you can focus on would be competence, so feeling that they're in control or a sense of mastery with the behavior, a sense of autonomy, which our first speaker talked about a little bit about. So, you know, if you think about all of yourselves, if you feel like you have a choice in something, you feel a lot better about that than when someone is telling you what to do. So we should respect people's autonomy and try to promote that. And finally is the concept of relatedness, so feeling connected and appreciated by others. So to improve people's intrinsic motivation or move them more towards it being intrinsically motivated, we can focus on these 3 areas. And so I've specifically given a few pointers on how to promote competence, autonomy, and relatedness. So when we look at competence, we can help people to set up achievable, flexible, realistic goals, and we can help them to develop the skills necessary to achieve those goals. And so then the person will feel a sense of mastery, and that will go on to lead them to continue to be motivated. If we have new exercisers, putting them in positions where they can see and hear, we want to set people up to be successful, using clear and appropriate communications strategies and being respectful of each individual's efforts. Some ways to increase autonomy: always give a menu of options. Let people have a choice in their exercise and what they're doing and how they're progressing. Talk to your patients and include them in the process. Relate exercise to the client's goals, not your goals. And avoid coercive or controlling language. So this would be things like saying, you really need to exercise or you're going to have another heart attack. So things like that really don't help motivate people to stick with being physically active, and we should avoid that type of language. It undermines helping these people move to being more intrinsically motivated. Finally, are opportunities to create relatedness or feeling connected. So you can help do this by assessing someone's social support systems. And if you can foster areas of support specifically for physical activity, that's going to help your client to be more successful. So there's a load of research out there to show that people that have more support do much better with behavior change, physical activity being one of those. So any way that we can feel an individual feel supported in making their lives more active, they're going to do better in the long run. So you can do that by having different types of classes with them. You can also serve as a means of support for your patients. And so just by communicating understanding or empathy of where they're coming from can help them feel supported by you. So our research on exercise adherence is not so good long term. So 50% of individuals drop out of an exercise program within the first 6 months. And so that's really why we're talking about all of this today, is how do you really help engage people, not only initially, but help them continue that behavior lifelong. Oftentimes our patients drop out of physical activity sometimes because they have a bad experience with it. So I work with clinical research studies, and sometimes if a patient has one bad experience, we lose them and we never see them again. So you really have to set people up to be successful and have it be a good experience. So oftentimes when we talk to people as to why they might have dropped out, they might say that they had pain, they just don't have the belief that they can continue this, they're embarrassed, all kinds of different things. So you really want to assess this with your patients and be able to help them to have a sense of belief that they continue this long term. So how do we change their experience with physical activity? So ACSM recognizes now that there are a variety of behavioral techniques that really can help individuals be physically active long term. So I took this quote from the guidelines. The art of exercise prescription is the successful integration of exercise science with behavioral techniques that result in long-term compliance and attainment of the individual's goals. So we have to continue to take into account all these physiological parameters, but we also have to take into account some psychological or behavioral parameters as well. So how do we build a psychological exercise prescription? And we'll go into this much further in the breakout session. And again, we have a lot of handouts that can help you to do this with your patients. But I'll briefly go through some techniques right now. So I just put some words up here that you can focus on with your patients. So you can have your patients as well as you can help them to assess. So assess what's going on with them. What are their values? What are their goals? What are their energy levels that day? Are they experience a lot of barriers towards physical activity? Do they have a lot of stress? And so maybe they have stress and a walk would be appropriate to relieve that stress. Maybe they have stress and a vigorous kickboxing class would be appropriate to help them relieve that stress. And so that all goes into talking to your patients, assessing what's going on with them, and then helping them choose the appropriate activities to meet their needs. Helping them to engage the senses can also help them to be moving from this extrinsically motivated physical activity to more intrinsically motivated physical activity, and we'll give you some ways that you can do that. And finally, reflecting after physical activity. How did it go? What was going on? What worked well? What didn't work so well? And what would you like to change in the future? So mindfulness comes in here as also being a technique that can help people to be more intrinsically motivated. So let's first start off by defining what mindfulness is. Mindfulness is a state of awareness, being present in the moment, free from judgment. It's observation of the way physical activity is going, but not judging yourself about that. It's not a passive state. Many people think that mindfulness is a passive state. It's not a passive state. We actually imply intention when we're being mindful, and that can be during physical activity. So how do we achieve mindfulness with our patients? So there's a variety of methods that I've listed here. Many of those you might already be encouraging your patients to do or actually working with your patients. Things like meditation, breathing, yoga, imagery, relaxation, stretching exercises. But mindfulness can also be incorporated while people are being physically active. So what is mindful exercise? So I apologize, these are a little bit small, so I'll go through them briefly. Mindful exercise acknowledges that there's lots of exercises that someone can do and perform mindfully. It accepts that individuals' physical activity abilities are unique, and those abilities can change over time. It focuses on exercise in the process, not just getting to the goal. And I think this is a really important one when we're encouraging mindful exercise. Accepts that individuals have physical limitations that are unique, and it pays attention to those limitations. Directs awareness by choice through our patients to all aspects of physical activity on a moment-by-moment basis. And it can look at immediate choices and direct experiences associated with physical activity and exercise. And finally, mindful exercise is reflective. So what would the benefits be to mindful exercise? So again, research has shown that people that are more mindful during physical activity, they have fewer missed exercise sessions, more regular exercise, greater self-efficacy, they don't drop out as much. So if we can't hold people in a physical activity program or have them continue it, we're never going to get the physiological benefits that we're looking for. So a lot of times if you start on the psychological side or behavioral side of things, you can end up getting the physiological parameters that you're going for. So one of the ways that we can help our participants think about their physical activity is to ask them to take a moment to think how you exercise or move your body currently. So are they aware of their posture? Are they looking forward to when it's over? Are they just doing it to do it and get it over with? What are their physical sensations while they're exercising? Is there any pain or discomfort? Are they aware of being in the zone or flow during physical activity? So research has found that intrinsically motivated and flow activities, or you can think of flow as being in the zone, which are characterized by engagement with and attention to what is occurring, yield considerable enjoyment and a sense of vitality. So if we can achieve this with our participants, they're going to be able to stick with physical activity much longer. So I know that I went through that very quickly since we don't have a lot of time, but we can go through this in more detail and answer your questions in the breakout session, and we have a handout for you that you can, again, use with your patients and some questionnaires that you can use to assess some of these things. So in summary, we want to help our patients get to a point where they think exercise is important, and they're doing it because they believe in it, not because we do. Some people can never actually come to enjoy physical activity. I know a lot of us don't understand that, but sometimes you can get people to, maybe they're not enjoying it like you would like them to, but they can come to value it, and that can still move them towards being more intrinsically motivated. If we can help transition our patients from saying that they should exercise to they want to exercise, we're going to be more successful with them continuing that physical activity throughout their life. And finally, developing a mindful moving plan can potentially help with moving our patients towards being more intrinsically motivated, which we know is associated with better long-term outcomes. So I just put this little cartoon up again, just again to have you consider, I know so many of us are concerned with these physiological parameters, but to also consider taking into account the psychological or the mind, what's going on with our participants. And again, a lot of times if we start there, we can end up on the other side. So thank you for your attention today. And in the breakout session, again, we'll give you a handout and we can talk through this physiological versus psychological prescription and how do you integrate the two of those to achieve health outcomes. Thank you.
Hi, I'm Carolyn Richardson from the University of Michigan. I'm a family physician, and I work at the Ann Arbor VA as well as a health services researcher, and I do a lot of research on pedometer-based walking programs. So, how does this work? So, wait a minute, I gotta go back one. Right click. So, okay, here we go. All right, so I'm going to start with a question, which is, do pedometer-based programs, walking programs, increase physical activity? Yes or no? And this is a question I get almost every day. And the simple way to answer this question is to say, is to cite the literature that says, you know, meta-analysis. This is one of the better pieces of literature around there by Bravada, published in JAMA in 2007, showing that pedometer-based walking programs actually do increase physical activity and they improve health outcomes as well. That's the simple answer, but in the healthcare setting, it's actually not the accurate answer. A more honest answer, a more nuanced answer is that some pedometer-based walking programs work for some people sometime. And so what I'm going to talk about in the next 15 minutes is a little bit about evidence-based optimization of pedometer-based walking programs in a healthcare setting for people with illness. And we're going to use, you know, some of the lessons we've talked about, some of the lessons that I've learned from 15 years of designing and evaluating pedometer-based walking programs for sedentary and sick people. So I'm going to start with a quote, and there's a number of quotes that are going to appear in this talk, and all of them are quotes that we hear over and over and over again. And the first one is one that we hear every single day in the clinic. I really want to lose weight, but nothing works. I'm on my feet and active all day, and I eat almost nothing, but I still keep gaining weight. Those exact words are repeated hundreds of times a day all over the country in physicians' offices. What do you think is going on here? But that's the picture of the mom with the kids running around is purposeful, because that's often the person who's saying this quote. But the part that's curious to me is, I'm on my feet and active all day, and I eat almost nothing, but I still keep gaining weight. How is that possible? Go ahead. She's lying. I'm glad you said that, because I needed someone to say that. When I give this talk to physicians, they say the patients lie all the time, and they get very negative about it. I'm not sure that patients are lying. Is there another explanation for what could be going on here?
Well, I think a couple of things. One is that sometimes people don't understand that being on their feet, being active, doesn't translate into exercise activity that is beneficial. They're busy, they're active, but they're not exercising, they're running around. And the other thing is that when people say they eat almost nothing, it could be true, but what are they eating? They're not eating the correct things, and what they are eating may be more calorie dense rather than healthy, and it's just structure. She is really well structured.
So I think all these are playing a little bit of a role. Anyone else have any thoughts about what else may be contributing?
It's a perception problem.
It's a perception problem. So I think that the perception problem is really the underlying issue. And all of these other things, they're lying, well, not really, but they're trying to appear like they're being a little more responsible about their health than they really are. So maybe they're twisting the truth a little bit. They're overwhelmed by all the things that are going around with them. They don't feel like they have control. All of the things that you've mentioned are contributing, but the underlying real core of what's going on is the perception problem. And what I call that is a failure of self-monitoring. And self-monitoring has a lot of different meanings in psychology and health behavior change. But what I'm referring to is a very simple concept of self-monitoring, which is if you don't know what your behavior is right now, you can't change it effectively. Most people do not know how much they walk every day. They have no idea. And, you know, the person in the last slide may be thinking, I feel stressed, tired, and stressed out, so I must have been walking all day. But in fact, they may have been sitting on the couch all day. But you know, when we put pedometers on these patients who say these things, they come back with about 3,000 steps on their pedometer in a day. We've had other patients who say, well, I worked a 12-hour shift, so I didn't have any time to exercise today. We put a pedometer on them, and they've got 21,000 steps because they're a nurse that walks up and down the halls all day. That's their job. The perception is so distorted in so many different ways, usually on the lower side, but occasionally on the higher side, that it's almost a completely useless exercise to ask people how much they walk. So we have a lot of pushes, exercises, medicine, ask your patients how much they exercise. Patients don't know how much they exercise, so asking them is an exercise in getting, and it's like a random number generator. And it's not useful. Subjective assessment of physical activity may be okay for some people, those who participate in structured activity. I go to Curves 3 times a week, and I usually go for an hour bike ride on the weekends. Marathon runners, even before they used GPS and tracking systems to do everything, often keep very careful track of how much exercise they do, maybe just with a stopwatch, but they know how many minutes they were running and how fast they were running. But it's really useless for people who mostly do lifestyle activity, and that's really most of the patients that we see in a medical care setting. The failure of self-monitoring, just to get it in your head concretely, since most of you are probably athletes, think about this. Think about the last time you ate a sit-down dinner with a fork and a knife. How many bites did you take during that meal? Does anyone know the answer to that question? There are people who know the answer to that question. Do you know who they are? People with obsessive compulsive disorder. That's what they do. They count things. And that's why they can't function in the real world, because they're so busy counting things that they can't interact and engage. And we give them medicine so that they can function better in the world. But most people don't know how many bites they eat. Most people don't know how many steps they take during the day. They have no idea. Here's another classic participant quote for some of our studies. It was very interesting to see all the detailed data about my physical activity, but I didn't really know what to do with it all. So it's one thing to give a pedometer to somebody at ACSM who has a history and an experience dealing with this kind of data. It's another thing to give a pedometer to an obese person with hypertension and cardiovascular disease who really hasn't thought about his physical activity in, ever. This problem is a huge problem in medical care settings and pedometer-based walking programs. And a third quote, this is a real quote. I've been wearing my pedometer for 4 weeks, and my step counts have not increased at all. What do I have to do to increase my physical activity? When I first heard this quote, and I've heard it many times, I thought I had misheard. I was like, did I miss something that you said? I don't get it. The first person that said it to me was actually a nurse in a clinical setting who was responsible for counseling people about physical activity and diet. And I couldn't believe that she was asking. It just didn't even make sense to me. But the level of understanding of physical activity is so much lower than for the average in this room that it's a little bit hard to believe what's going on in people's minds when you're talking to them about physical activity. And part of the reason that these patients are ending up as patients in our healthcare system is because the level of understanding and the cognitive processes that would effectively help them to do better at physical activity are so primitive and so lacking in real cognitive abilities to understand what they need to do is so low that it's almost unbelievable. And it's only because I've been working with these patients for 15 years that when I hear this quote now, I don't do what I did the first time I heard it, which is just like my jaw drops and I can't even respond because I don't even know what they're talking about. But when you counsel patients who don't know much about physical activity, this is often what they're thinking. What good does it do to wear a pedometer? It hasn't changed my walking at all. It's by magic somehow going to make them walk more, like one of those machines that you wear around your belly and it shakes and it makes your belly fat go away. That's not what a pedometer is, right? But People don't always know that, shockingly. Even relatively well-educated medical personnel don't always know that. Accurate self-monitoring is necessary but not sufficient for behavior change. If you can't self-monitor, you can't plan, set goals, reward successes, discuss progress with others, or learn from failures, but there's a corollary to that. Just because you can accurately self-monitor does not mean that you can plan, set goals, reward successes, or discuss with others, or learn from your failures. And so that's where the context within which we set up a pedometer-based walking program really starts to matter. So back to the Bravada meta-analysis, one of the findings in this meta-analysis was that those pedometer-based walking programs that were the most successful at increasing physical activity and improving health outcomes were those that had very specific, concrete goal-setting plans. And so I'm going to talk a little bit about goal setting in the context of the medical setting with patients who are often pretty sick and not very active. One of our first studies was to compare goal setting that used total daily steps versus bouts or aerobic steps. And there are pedometers that will record both. And we were able to take the data, feed it back to the patient in a web server and say, your step count goal for the next week is every day we want you to walk 6,000 steps total for one arm. And for the other arm, we said, your goal is to walk at least one 10-minute bout of walking that gets you at least 1,000 steps by the end of the day. And all the other steps that you do outside of that bout don't count towards your goal, but it's a lower goal. What we found was very interesting. There's really no difference between those two types of goal setting as far as how physically active people are as long as they remain in the program. But the total step group liked it better and were more adherent and stuck with it more. And this may go back to some of what our other speakers have talked about, where giving very prescribed, you have to do it in this way, takes autonomy away, and it gives less credit for small amounts of movement, and that's less motivating. Here's a picture, a graph of one of our participants to whom we gave a total step count goal. And one of the things you can see here is that before day 0, on the bottom is the days of the program, the green dots are the bout steps or the aerobic steps that were taken during bouts of 10 minutes or more of walking. He didn't do any, 0. And then we gave him, this participant got step count goals. They got total daily step count goals, not bout step count goals. But as his daily step count goals gradually incremented across the program, how did he meet his total daily step count goals? He met it by increasing his bout steps, because that's what happens when you plan physical activity. It's just too hard to increase your physical activity in small increments throughout the day. Most people just say, all right, fine, I'm going to go for a walk. And so even though we gave different goals, the behavior change was similar, but the reaction to the program was much more positive, higher satisfaction, more likely to recommend it to a friend. They wore the pedometer more days. They stuck with the program longer in the total daily step count program. So we've really switched over to total daily steps pretty much exclusively, even though there's a physiologic argument for doing bout steps in many cases. And I want to talk about a little bit about goal-setting controversy. We've heard a lot about motivational interviewing and intrinsic versus extrinsic motivation. And in most of our studies, we tend to assign step count goals. We do it in an individualized basis, and we take into consideration the patient's context and their illness. And that's very important in a medical setting for safety reasons. But a lot of people don't like assigning goals because it isn't consistent with the intrinsic motivation plan. And we know that intrinsic is better. And there's a lot of data to support that. So why do we assign goals? Well, first of all, it's important to understand that goals are not one thing. There's not, all goals do not behave the same way. All goals are not equal in the terms of how important intrinsic motivation is. So I want to talk about a little bit about what Carver and Schreier call higher order goals and lower order goals. Higher order goals are like, I want to be alive for my daughter's wedding. Or I want to be able to play football with my grandson. Those are very values-driven, individually meaningful, salient goals. Lower order goals are like, well, I'm going to walk 5,000 steps today. There's not a lot of value or intrinsic motivation associated with whether you pick 5,000 steps a day or 5,500 steps a day to be your goal. That's not a goal that has a lot of value behind it. In fact, people don't even really understand what the difference between those two things would be. So how could they have a lot of meaning behind that? So what often happens when you have motivational interviewing discussions about step count goals is the patient says, "Doc, just tell me what to do, and I'll do it." So you have to be a little careful with that, because we find that people will do what we tell them to do with step counts. If you tell them to walk 10,000 steps, they will walk 10,000 steps. And if they have coronary artery disease and weigh 400 pounds and haven't gotten off the couch in 40 years, that's a problem. Optimizing motivational effects of this goal setting, not too high, not too low. That's basically the take-home message from the theory of goal setting by Locke and Latham. Too low is not motivating. Too high, people give up. Everybody has a different too high and too low in the medical setting. It's not as true among healthy individuals outside of the medical setting. Most people who don't have chronic disease or acute illness are able to do a fair amount of walking. 10,000 steps is probably a reasonable goal. They could probably even jump right up to it right away and not get seriously injured. That is not true in the medical setting. Everyone needs their individualized goal. It needs to be based on where they are right now. It needs to be gradually incremented to reduce dropout and injury rates. We have developed weekly goal-setting algorithms that basically add an increment by asking our patients in many trials over time whether they thought our goals were incrementing too rapidly, just about right, or the goals were too easy. We found that an increment of about 600 steps a day works for very sick and frail patients. We have done that in patients with COPD and back pain. 800 steps a day works for obese and sedentary but not too sick patients with hypertension or diabetes. And 1,000 steps a day you can get away with in most young and healthy but sedentary patients. And again, for healthy active, you can consider a fixed one-time increment of 3,000 steps from the beginning because they're less likely to drop out and less likely to get injured. Action planning comes from cognitive behavioral therapy, and this is addressing the issue of what do I have to do to make my step count increase? And you really do have to help people plan ahead, write down a plan for when they're going to take a walking session, write it in their calendar, do the planning weekly, and it needs to be fairly detailed, when, where, and how. And that's a component that's left out of a lot of pedometer-based walking programs, but it's critical. We looked a little bit at social support and communication. One of the things mentioned by a previous speaker was the idea that you connect people to other people like them. And in the medical setting, that's particularly important because if a patient has COPD and they say, well, that sounds like a really great exercise program, but I have COPD. And they're automatically assuming that it's not for them. And so we create programs that are walking programs just for patients with COPD. And patients love it, and they don't ever have that moment where they're thinking, oh, this isn't for me, this is talking about someone else. And so we got an online community for patients with heart disease, for diabetes, for obesity. We had patients talk to each other. And what we found, and we put them on this web-delivered, web-mediated walking program with automated incremental goal setting, tailored motivational messaging, and feedback. And what we found was in the two groups, there was a group that got to talk to other patients in an online community, and a group that didn't get to talk to other patients like them in the online community. They just had their own individualized walking program. And we didn't really see much difference in step count increases. They both increased their step counts quite a bit over the course of the program. But what we did see was a higher dropout rate in the group that did not have access to other patients. So often we worry about dropout, we worry about adherence, long-term adherence, and we find that having an online community of patients like me helps people to stay in the program. So the last part of my talk is just about limitations. Pedometer programs are not for everyone. And a gross oversimplification is that there are two kinds of patients, the patients who are asking, why should I walk, and the patients who want to know how I should walk. The whys are the people that really are skeptics, and they need individually relevant evidence of benefit. They need motivational interviewing to elicit a discrepancy between their values and their behaviors. They need experiences with success, and sometimes they need very large financial incentives. The how people are already motivated. They need behavioral skills, goal setting, self-monitoring, social support, accountability, and everybody needs experience with success. Some people don't want or need pedometers. They walk the same exact route every day. Maybe it's a quarter mile around their block, and they gradually increment that by saying, okay, well, today I'll do 2 laps, and now I'm at a half a mile. You don't need a pedometer if that's what you're doing. Some people just find a pedometer of any kind to be too extrinsic, too big brother-like, too much like it's not, it's somebody's watching me and I don't like it. Those are often sort of the feeling yoga types who like to be a little bit more disassociated during their exercise practice, or mindful, depending on how you look at it. And then there's people who are just anti-technology. They just don't want it. And the older you get and the sicker you get, the more anti-technology you get. Younger veterans who are actually pretty pro-technology and pretty comfortable with it don't like pedometers. But it's not for the same reason. They don't like it because they think walking is for sissies. It doesn't matter that they've lost both of their legs and have traumatic brain injury and they can't actually do anything, even probably walking anymore. Walking is for sissies, and it's not going to help them no matter what you tell them. They want to do weightlifting. They want to do push-ups and pull-ups because that's what they've always done. And monitoring physical activity using pedometers isn't going to work for them. So when we do stuff where we want to look at weightlifting or swimming or cycling, we switch to different devices that actually can monitor that kinds of exercise that they do a little bit more accurate, like the Body Media Fit. Not all evidence of pedometer-based walking programs is positive. There are many, many, many studies out there now where the pedometer didn't really seem to add much. This is an example of a study in older adults with type 2 diabetes, exactly the group that the medical community really wants to get walking and that should respond to these pedometer-based walking programs. And they did a study with 2 arms. One of them was a coaching program, and one of them was a coaching program plus a pedometer. And there was no difference in outcomes between these 2 arms in the study. And none of these papers that show this have enough detail about how they used the data, how they developed the goal-setting program, how they communicated to the patient to help us understand what was it that made the typical feedback and goal-setting approach not work in this setting. Postpartum women, people have tried pedometer-based walking programs 100 times in postpartum women. Very few of them show any benefit at all. These women need something else. They're so distracted and so tired and have so many competing demands that they're one of the hardest groups to move. So take-home messages. Pedometers do improve self-monitoring. The more sedentary you are, the more they improve self-monitoring. Step-out goal setting is difficult for some patients and is a critical component of a successful program. Sometimes you need to be a little bit directive about it. Social support improves adherence and retention to these pedometer-based walking programs, especially when you can bring the social support within the context of a community who has the same disease that you have. And think carefully about your target population before implementing a pedometer-based walking program, because it may change how you implement it, how you increment the goals, what kind of device you use to monitor the physical activity. And this is my last quote. Patient quote was posted on one of our websites for patients with COPD. He says, "I had a big shock on Monday when I called to get my oxygen tanks refilled. They said I no longer was on daytime oxygen. I've been on oxygen 24/7 for 12 years. I called my VA doctor and was informed I passed my walking test. The only change in my life has been the walking program. I have a long way to go, but at least I can see some progress." So sometimes it works. That's it.